Welcome everyone, and thank you for joining this session on infection control in adult and pediatric ICU. Today we will explore the burden of hospital acquired infections in the ICU, understand why the risk is so high, and review evidence based strategies to reduce infection rates and improve patient outcomes. Let me start with global prevalence of ICU acquired infections. Rates vary drastically from 5% in the United States to 50% in India. VAP is the most commonly reported healthcare associated infection. Up to half of ICU patients can acquire an HAI during their stay in ICU. ICU patients face a 5 to 10 times higher risk of infection compared to general ward patients. The mortality attributed to these ranges from 20 to 50% depending upon the site and causative pathogen. These infections extend ICU stay by an average of 5 to 10 days and significantly increase cost and resource utilization. So let's now discuss the unique environment and risk factors in ICU which make them highly susceptible to healthcare associated infections. ICU patients are often immunocompromised with multiple comorbidities like diabetes, cancer, and advanced age. Frequent use of central lines, endotracheal tubes, catheters, and life supports like dialysis and extracorporeal membrane oxygenation increases infection risk in these patients by many times. These patients need constant care, for example, positioning, physiotherapy, drug administration, feeding, and investigations. Staff spend a large percent of time of their work hours in direct patient contact. This increases transmission opportunities. High antibiotic usage is a norm in ICUs. This can be around 50% of the ICU patients receiving antibiotics in Western world to about 90 or more percentage of patients receiving antibiotics in India. This leads to development of resistance among the organisms, among the flora of the patient, and raises the risk of not just infection but also multi-drug resistant infections. Time pressure during emergencies like cardiac arrest, which are not so uncommon in ICU, often leads to suboptimal infection control precautions. Obviously, in such dire emergencies, proper hand hygiene and contact precautions are sometimes bypassed. So, now let's talk about core infection control strategies in ICUs in general and about prevention of specific healthcare associated infection in ICUs like VAP, CRBSI, CORTI, and some other. So, let's start with ICU design. The ICU environment should minimize infection risk by locating ICU away from unrelated traffic. Ideally, there should be a single separate room for each patient of at least an area of 150 square feet. If the patients are placed in a single hall, each patient should get at least 130 square feet of area. There should be negative pressure rooms for airborne isolation. For every 8 beds, there should be a single negative pressure room, and also there should be positive pressure rooms for protection of immunosuppressed patients like patients post bone marrow transplant. And last but not the least, there should be adequate nursing staff. The ratio, the higher the ratio, the better. Ideally, there should be 1:1 nursing so that the cross contamination and cross infection is reduced. Using cleanable surfaces and avoiding decorative fixtures, fountains, carpet, or closed sittings is paramount in ICU design. Hands of healthcare workers harbor millions of bacteria, viruses, and fungi, and they are the seminal route of transmission of infection in ICU. Hand hygiene remains the single most effective preventive measures against healthcare associated infection. Hanging a hand rub at the bedside is probably the most effective thing to control HAI in ICU, and if you can do only a single intervention, you must do this. Unfortunately, the compliance rate rarely exceeds 60% throughout the world, and in low income countries it can be as low as 9%. Hand hygiene can be performed either by washing with soap and water or with an alcohol based hand rub. The alcohol based hand rub is faster and more effective as compared to soap and water. It also causes less skin irritation and thus has a better compliance among healthcare workers. However, soap and water is absolutely necessary if your hands are visibly soiled or if you are in contact with a patient with Clostridium difficile infection, because the spores of these organisms are not killed by alcohol based hand rubs and you need to scrub them out with the help of soap and water. A hand washing station should be conveniently located and there should be one for every 4 to 5 beds of ICU. It should be of hands free operation and proper supply including paper towel must be available, and ideally there should be no mirrors. Always perform hand hygiene before and after touching a patient and after touching his surroundings and before performing procedures and after body fluid exposure. Gloves do not replace hand hygiene. Disinfect hands after glove removal and before putting gloves on. Infection can be transmitted in ICU by contact, direct or indirect through the environment, and this is the most important route of transmission. Other routes are through droplets, which are particles of more than 5 micrometers and travel short distances, or through airborne transmission by smaller particles which travel long distances. To break this transmission, the CDC recommends a two-tier approach. First is the standard precaution, which are to be followed for all patients whether they are infected or not. And the second is transmission-based precautions for patients with highly transmissible or epidemiologically important infections. These routes are airborne, droplet or contact. Hand hygiene is the cornerstone of standard precaution and should be performed before examining every patient whether he is infected or not. Gloves are needed if there is a chance of touching blood, body fluids, secretions, broken skin or mucous membrane. And mask and eye protection and gown is additionally needed if there is a chance of splashing during procedures. Contact precautions are the most important in ICU and need to be taken for most of the infected patients, especially for patients harboring MDR bacteria, fungi or Clostridium difficile. Besides hand hygiene, it involves wearing gown and gloves at door and using dedicated equipments like stethoscopes. Droplet precautions protect against infections like influenza and Neisseria meningitis and diphtheria. A healthcare worker should wear a surgical mask and eyewear when coming in close proximity, that is within 1 to 2 meters, to the patient harboring these infections. Airborne transmission involves tiny particles that remain suspended and can travel several meters. Diseases like tuberculosis, measles, and varicella fall into this category. Prevention needs a negative pressure room and a N95 mask must be worn by healthcare workers who are entering into these rooms. A negative pressure isolation room prevents spread of infection which are airborne like TB and protect others from these. They maintain a negative pressure of minus 2.5 pascals relative to the corridor or rest of ICU, leading to flow of air from corridor to the room so that the infected airborne particles are not transmitted from the room to the rest of the ICU. A positive pressure room reduces the risk of airborne transmission of infection to a susceptible patient, for example a neutropenic patient or a post bone marrow transplant patient, by maintaining a positive pressure and flow of air from patient room to the corridor. The ICU environment serves as a reservoir for MDROs and other pathogens and has been connected to several outbreaks. Several surfaces in an ICU harbor organisms like methicillin-resistant Staph aureus, Acinetobacter baumannii, where they can survive for days or weeks. Wet sites like sink harbor gram-negative bacilli like Pseudomonas aeruginosa, and ICU linen and curtains can harbor Clostridium difficile. The environment acquires these from colonized or infected patients, and then the patient acquires it from the environment directly or through the hands of healthcare worker. Proper and frequent cleaning of the ICU environment requires to break this chain of transmission. High touch surfaces like bed rails, tables, door handles, monitors and bedside curtains should be disinfected at least twice daily and more often when soiled. 70 to 90% alcohol, hypochlorite solutions or hydrogen peroxide with ensuring proper contact time should be used for environmental cleaning, and terminal cleaning post discharge is mandatory, which includes thorough disinfection of surfaces and floor and replacement or laundering of linens and curtains. Shared ICU equipment must be appropriately disinfected or sterilized based on risk. Critical items like surgical tools require sterilization. Semi-critical like laryngoscopes which come in contact with the mucous membrane requires high level disinfection with glutaraldehyde or orthoparaldehyde, while non-critical items like blood pressure cuffs and ultrasound probes require low level disinfection with alcohol or quaternary ammonium wipes. So friends, now let's discuss about specific healthcare associated infections, starting with VAP, that is ventilator-associated pneumonia. VAP is defined as a pneumonia occurring more than 48 hours after endotracheal intubation. Mind you, there are different surveillance definitions of VAP which are used by infection control teams and hospitals. These includes ventilator-associated events, ventilator-associated conditions, infection-associated ventilator-associated conditions, and possible or probable VAP. In the US, the rate of VAP is 1.1 per 1000 ventilator days. However, in low and mid-income countries, it climbs to 12 plus per 1000. VAP results in significantly longer ICU stay and higher cost and increased mortality. Let's now examine how VAP develops. When an endotracheal tube is in place, the body's natural defense are bypassed, allowing oropharyngeal and hospital-acquired MDR organisms to colonize the upper airway and form biofilms on the tube. These are then micro-aspirated into the lower trachea and the lungs, which is the key process here. Secretions pooled above the cuff leak into the lower respiratory tract, and this subglottic pooling is a particularly important contributor. So, our interventions must target this risk. What can be done to prevent VAP? It is not just the bundled interventions, which though are evidence based, but we need other things like educating the staff, appropriate surveillance, monitoring compliance, reporting rates of VAP to the stakeholders, and providing feedback to the healthcare workers. Now let's focus on the bundle based high yield strategy. First and foremost is to avoid the intubation altogether wherever it is possible. This can be accomplished by early use of non-invasive ventilation or high flow nasal cannula, which have been shown to reduce the rate of intubation. So if there is no intubation, there is no VAP. Second is the shortening of duration of mechanical ventilation, as each day on mechanical ventilation increases the risk of VAP by 7%. This can be accomplished by reducing sedation, giving better sedative drugs like dexmedetomidine, and performing daily spontaneous breathing trials. Another simple intervention is to maintain the head of bed elevated at 30 to 45 degrees. This reduces regurgitation and microaspiration of gastric contents, and thus has been shown to reduce the incidence of VAP. We must perform regular oral care with toothbrushing and use devices that maintain cuff pressure consistently, aiming to keep the secretions above the cuff and prevent its aspiration. Initiate enteral feeding early rather than parenteral nutrition, as this supports gut integrity and immune function and prevents the translocation of the bacteria through the gut mucosa. We must try to use endotracheal tubes with subglottic ports. These are small openings just above the cuff of the endotracheal tube, and from here we can aspirate the secretions, the subglottic secretions, the secretions which are below the vocal cords but above the cuff, and they tend to accumulate there, and then later on they are microaspirated on the sides of the cuff to the lung. So if we continuously aspirate these secretions, the incidence of aspiration and pneumonia decreases. Early tracheostomy should be considered if prolonged ventilation is anticipated. Some interventions like silver coated ATTs, which are antibacterial or antiviral closed suction systems, have mixed evidence and are not recommended for routine use, but can be applied if VAP rate remains high. Chlorhexidine mouthwashes, though previously recommended, and the use of probiotics in ICU can be harmful and can even increase the VAP rates and should not be used. Endotracheal tubes with ultra-thin polyethylene cuff or tapered cuff, as seen in this pic, and kinetic beds are not useful solely to prevent the incidence of ventilator-associated pneumonia and should not be incorporated. Also, other previously commonly done practices such as routine changing of ventilatory circuits or monitoring gastric residual volume do not decrease VAP incidence and may be omitted. In summary, VAP prevention bundle centers on averting intubation, minimizing sedation, maintaining correct positioning, ensuring oral care and suctioning, and rigorous staff engagement. Vigilance, education, and adherence are the cornerstone of successful VAP reduction. Next, let's discuss about central line associated bloodstream infection or CLABSI, which is a very high burden healthcare acquired infection in the ICUs. Indian data reveals a CLABSI rate of 8.83 per 1000 central line days, nearly 10 times the US ICU benchmark. Neonatal rates are highest, followed by adults and then pediatric ICUs. Mortality can reach up to 40.6% by day 14 and this makes this a critical patient safety issue. In Indian ICUs, CLABSI is mostly due to gram-negative bacilli, about 80% are carbapenem resistant, Enterobacteriaceae, and 10% Candida. These pathogens pose significant therapeutic challenges. So, understanding roots of infection will help us to target prevention. Skin or environmental microbes can directly enter the bloodstream during catheter insertion. Skin flora migrates along the catheter tract, especially causing early infection less than 7 days after insertion. Later on, the infection arises from contamination of the catheter hub or the infusate with colonization of the internal lumen. Rarely distant infection sites may seed the catheter through the blood. During insertion, use aseptic technique with full body dripping as shown in this pic and employ 2% chlorhexidine gluconate for skin asepsis. Always use maximum sterile barrier precaution Besides this, the standardized insertion checklist should be used and observation and feedback by a dedicated person should be performed. Regarding the site where the central line should be inserted, the subclavian way is preferred for the lowest risk of infection. However, it cannot be used in patients with CKD as it hampers the future prospects of um, establishing a fistula for these patients on the same side of the body. The peripherally inserted central lines, which are inserted peripherally but reach the central veins, have there is a common belief that this reduces the incidence of CLABSI. However, this is not true in the ICU and should not be preferred over central lines just for reducing the incidence of CLABSI. However, midline catheters may offer some advantage regarding the incidence of CLABSI and can be used if feasible. Disinfect the catheter hub and access port before every use, ideally with alcohol swab. This is one of the most important step which can prevent the development of CLABSI. The chlorhexidine dressing should be used on CVC sites, especially in areas where the incidence is high, and in India it should be routinely used. Assess the necessity for CVC daily and remove as soon as clinically possible. Additionally, use needleless connectors and appropriate dressings. Like the dressing should be transparent and should not be changed routinely unless soiled. Limit the number of lumens to as much as required. Use single lumen catheters unless multi-lumen catheters are necessary. Ongoing staff education, regular audits, and feedback loops are critical for sustained improvement. By empowering all staff to enforce safety checks and closing the loop on feedback, infection rates drop from 2.7 per thousand line days to 0 in over 100 ICU in the state of Michigan in this study by the name of Michigan Keystone ICU Project. In summary, CLABSI prevention relies on rigorous insertion and maintenance protocols, empowered teams, and daily necessity review. The goal of zero CLABSI is a realistic and essential objective for every ICU. Now let's talk about catheter-associated urinary tract infection. 3 to 10% of catheterized ICU patients develop CORTI daily. After 30 days, nearly all will have bacteriuria. The risk of CORTI increases cumulatively by about 5% with each day of catheterization, and preventing CORTI is crucial for patient safety and reducing healthcare cost. Extraluminal infection occurs early after catheter insertion as the microbes from the periurethral and perineal area or external catheter surface ascend into the bladder, especially if aseptic technique is breached during insertion or maintenance of the catheter. The intraluminal infection occurs due to breaks in the closed drainage system or contamination of the catheter drainage bag or tubing. Urine stasis inside the bladder or drainage bag encourage antimicrobial growth. Restricting catheter use to appropriate clinical indications is the first preventing step. It should be inserted only for frequent urine output monitoring in critically ill patient. For example, patient of CHF on high dose diuretics or fluid resuscitation in a patient with shock and AKI. Other important indication is symptomatic retention or more than 500 ml volume on bladder ultrasound. Stringent aseptic precaution including hand hygiene, sterile gloves and drapes should be used while inserting the catheter. The jelly used should be a single used disposable jelly and the smallest possible size of catheter. To prevent injury to the urethra must be used. Once inserted, meticulous catheter care is essential to prevent infection. Secure the catheter well. This is done by applying some tape or micropore and fixing the catheter to the thigh. Sterile closed drainage system should be maintained at all times, and catheter and urobag should not be disconnected and at any time. The drainage bag should always remain below the level of the bladder. It should never be lifted above the bladder, which will lead to infected urine from the urobag going back to the bladder. Also avoid dependent loops or kinks, which leads to stasis and infection of the urine. The single most effective strategy to prevent CORTI is to remove the catheter as soon as no longer clinically necessary. Daily assessment of catheter need should be embedded in ICU protocols. Alternatives such as condom catheters or intermittent catheterization can be considered when appropriate. So I will talk in short about Clostridium difficile infection, which is caused by the spores of this gram-positive bacteria, Clostridium difficile. The most important ICU interventions are hand washing, not with alcohol, but with soap and water, as the removal of the spores of this organism requires scrubbing with soap and water. Another important intervention is prompt recognition, treatment, and isolation. Patient should be given a single room, and contact precautions should be followed till the diarrhea has subsided for more than 48 hours. Another common infection is surgical site infection, that is the infection of the site of operation. There are many interventions which help reduce these infections. However, specific to the ICU is to avoid hypoxia and hypothermia, which increase the incidence of surgical site infection. Another important intervention is proper prophylactic antibiotic therapy and antibiotic stewardship in these patients. So with this, I will stop our session today. Thank you for attending. If there are any questions, I am happy to take them.